Hi, I'm Dr. Michael Miyasaki, and I realized that being a good dentist just wasn't enough, not in today's economy. My practice needed something that would make us more distinctive and have a distinctive philosophy that our patients would really value, that my team would understand, and that I could really be passionate about. I've been practicing dentistry for almost 40 years. And in those 40 years, I've had to fill a lot of teeth, had to pull some teeth, place implants. That's kind of what dentistry is all about. And I think that's the type of dentistry our patients think we provide as dentists. We try to clean their gums, we try to find the decay before it gets too big, and then we fill it. Well, I'm really excited because I think in today's dental environment, that dentistry 2.0 is more about filling holes. It's about protecting the teeth and the gums. And I think that is the exciting part of our profession today. It doesn't mean you're not going to be able to feed your family. It's just you're going to find those patients that really value good dental health, and you're going to be able to provide them a lot of services and still feed the family and do very well. So what I'm going to talk about is a brief overview of what I'm going to talk about over the next few months. In the next few months, we're going to talk about Dentistry 2.0, and that is trying to detect risk areas for gum disease and for tooth disease. It could be white spot lesions or it could be full out decay. And then what we're going to talk about is how we've been practicing Dentistry 1.0, and that was what I learned in dental school, where we'd wait until there was disease, there was gum disease, and then we would do surgery because we had the deep pockets that we could measure. Or we'd have our bite wing radiographs and I'd see the decay, and then I could do a filling or a crown because we had the disease documented. But we were waiting for that disease to be documentable so that we could be reimbursed by the insurance companies. Today I really feel that patients would rather stay healthy than wait until disease develops. Because we know once disease develops, whether it be in our systemic system or in our oral environment, that a repair is never quite as good as the natural tooth. A stent placed in the heart can keep you alive, but it's not as good as the blood vessels that it's repairing. So we would rather be preventive in our health than reparative in our health. So what we're trying to do now is we're trying to, in Dentistry 2.0, develop the risk areas earlier with new technology that's available today, and it doesn't cost a whole lot. And then we can use some of the new materials to actually modify areas of the gum and teeth. And then we can use some new materials and technology to actually repair the teeth if need be. And again, we hope we don't have to. So I think that's how practice becomes different, not in the services we provide necessarily, but by following a meaningful philosophy. And by meaningful, I mean really to our patients. So what we're going to do is instead of waiting to fill holes, we're going to try to protect the teeth and prevent gum disease. And, I really think it starts with the simple question. When we place a filling even, what exactly are we doing? Are we trying to fill or repair a tooth and maybe a defect in that tooth? Or are we really still trying to protect the tooth so that that filling doesn't have to be replaced, eventually maybe becoming a crown that maybe needs an endodontic procedure, and then ultimately may fail and need an implant after it is extracted. So what we're trying to do is we're going to talk about how we protect the teeth. And this isn't new technology. This is technology that I've been using in the practice for over 5 years. And so for much of our career, as I mentioned, we found decay, removed the decay, we placed the restoration and told the patient, okay, we're all taken care of. But were we really taking care of everything? We repaired the damage, but we didn't really change the conditions that caused that damage. And today we know that a lot of that damage is caused by biofilm. Biofilm is bacteria that has matured. And once it's matured, it becomes a communicating community that's harder to dismantle, that can prevent or that can cause more severe disease. So if I can identify biofilm at the gum line and I can modify it, that is important to do. If I can identify the biofilm between the teeth or in areas that were at high risk of decay, and I can modify that, then that's what we would rather try to do. So are we choosing materials that can occupy space or materials that actually can go on to provide that tooth with protection? Are we able to conserve the tooth structure? So if I have a filling that's small, then it gets medium, then maybe large, can I reinforce that filling material so that we don't have a fracture or so we can maybe prevent the need for a crown? So as dentistry becomes increasingly commoditized, we're talking to patients who call and they go, hey, can I get that $99 special for an exam and a cleaning? We don't have that special. They're joking. But I think our patients are seeing those advertisements. Cleanings, crowns for a certain fee, implants for a certain fee, veneers, even clear liners. And these marketing pieces are everywhere. They're on billboards, they're in mailers, they're on TV. And because of that, I think what they start doing is they start focusing on the price. And they start thinking that one practice is the same as every other dental practice. But those of us that practice dentistry know that that's not the case. So if they're making those decisions based on the marketing pieces, they might be trying to find an office that accepts their insurance. That's the closest to where they live or work, who can see them first, and who charges less. And really, those aren't the most important reasons that you would pick a dental practice or maybe a medical provider even. You want to go to the best. And you want to go to those that are really focused on prevention of disease, not waiting for disease to happen. So I don't want patients to choose our practice because we appear to offer the same dentistry for a slightly different price. I want them to recognize that we see their health differently. So differentiation is not having better equipment or carrying different products, because our patients really don't know what we're using or what kind of materials we're using. I think it's the differentiation has to mean that we have a clear philosophy that influences how we examine the patients. Do we do a comprehensive exam, or do we try to squeeze the exam in at the end of a cleaning? What do we show them? Do we show them the areas where disease can occur, where the risk is the highest? Do we help explain that disease to them so that they know how we're going to try to combat that disease from getting worse? What are the treatments that we recommend? Are they minimally invasive treatments so we can conserve tooth structure? And then what about the materials we use? Are they materials that will help prevent more decay from happening in their mouth? And how much tooth structure can we maintain? Because we try to use the most minimally invasive treatment we can. And then what do we do after we render any kind of treatment so that the disease doesn't progress or reoccur? And for me, it's that philosophy that defines Dentistry 2.0. The stakes are significant because every restoration begins a potential life cycle. A small restoration becomes a larger one. That large restoration may develop into a crown. That crown may need an endodontic procedure, and then eventually it may become unrestorable, and the final result is extraction, maybe replacement. But I think what we have to understand is that that was a progression when I was first learning dentistry decades ago. But today, with what we have, we may not have to have our patients follow that progression. And we can deliberately interrupt that pathway. And I think that, again, is Dentistry 2.0. How do we interrupt that pathway and keep our treatments as minimally invasive as possible? So Dentistry 1.0, again, is, I think, where the dental industry got wrong. We were reactive. We wait for disease because insurance required disease to be documented, and then we treat it. As I mentioned before, patients today want something different. They want to stay healthy. They want us to help prevent problems, not wait and then just repair them. So what we're doing today is we're not just treating teeth with Q-Bliss. I'll explain Q-Bliss. That's a way that we can identify risk areas. Then we can modify that risk using ParaProtect products and other Vista Apex products and technologies. And we'll talk about that today and in future programs that we do. With this, we're able to help our patients understand the disease and what's happening in their mouth, where it's happening in the mouth, and then we can show them ways that maybe we prevent those risk factors from developing into bigger problems. That is being proactive, and in my mind, that's Dentistry 2.0. And I think that's the important thing that we're trying to emphasize in our practice today. So the turning point was realizing that dentistry didn't have to begin with the whole. We could identify the risks. And that risk was typically where the biofilm was. And if we could detect those changes and where the biofilm was, we could do this before the patient felt sensitivity, before they felt pain, and before the traditional restoration would become obvious, at least a need for that, before traditional treatment would be needed. And it could begin long before a restoration was needed. So that began to change the questions I was asking. Instead of asking what needs to be repaired today, I began asking, now why did this happen? Where else is a patient at risk? Can the patient actually see what it is that we're discussing with them? And then if we detect these areas early, can we modify the environment that produces disease or that produce disease? And then can we strengthen those areas of the teeth? Can we help the gums be healthier? Can we use our restorative products to do more than just fill the holes, but actually help to prevent disease? Can we reinforce the tooth so that we don't have to do a crown, but we can have a large, predictable, direct restoration that will preserve tooth structure? And then how do we help the teeth last longer? As our lifespans are increasing, we need to have our restorations last longer. And again, these are the questions that are foundational for Dentistry 2.0. So what is Dentistry 2.0? We detect earlier. So what we're going to do is we're going to use different equipment to detect disease. And this is IOBio's Q-Bliss. That there's 4 different cameras basically that helps us visualize that biofilm. And when we can visualize the biofilm, we can show our patients that biofilm. Because here you can see at the gum line of these implants, there's plaque up there. But with this intraoral camera image, if I tell the patient, see that stuff up there? They go, yeah, I see it. But do they really see it? Now, if I use this biofluorescence technology and I show them that same image and I tell them where the red is, that's bad. That is where there's mature biofilm, bacteria that didn't just develop since your last meal, but it's been there for days. And it's that bacteria in that area that's mature that's going to cause gum inflammation and bone loss. And you know, these implants you spent thousands of dollars for, they're going to fall out, just like the teeth that they are there to replace. We rendered a treatment for this patient, but we didn't take care of the disease, the cause. So they may hear biofilm, demineralization, gingival inflammation, but oftentimes those terms remain abstract to the patient. You went through years of training to understand this. They get 5 minutes in the chair and all these complex terms. They don't really appreciate what it is that your periodontal chart shows them, the numbers. They may not appreciate a radiograph. Remember, you got to take radiology in school to understand what the black, white, and gray areas meant. But when a patient can visualize areas like they can here with the red, and we explain to them that the red is bad, now they understand what it is that we're up against. We're no longer just telling them a story, but we're showing them the characters in that story, the villains, so to speak. And so now we create an opportunity for earlier detection, better patient education, more objective documentation. We can track this over time. We see a lot of red today. Is that red what we're going to see 3, 4, 6 months down the road when the patient returns? So we can monitor how they're doing over time. And then we create patient participation. Tell the patient, I need you to help me keep this red at bay. Because otherwise, we are going to get swollen gums and bone loss. So this IO bio equipment is not just another intraoral camera, but it's an imaging device that really helps this Dentistry 2.0. And it becomes the beginning of our story. It helps us to answer, where is the disease developing, and is our intervention changing what we see? So what is that intervention? Well, we have identified mature biofilm. Now we have to modify that. Now, if this is a hygiene visit, hopefully we're getting all that biofilm out. All that bacteria is being removed. But if we don't see the patient for 3, 4, or 6 months, what's happening? That biofilm is repopulating that area. So once we identify that area of concern to us, that environment, we need to help it move towards health. So the oral biofilm can exist in relative balance with the patient, a symbiotic state, where we have good bacteria up there. But if we don't remove the bad bacteria, it keeps building up the pathogenic bacteria. And eventually this environment turns into a dyssymbiotic environment where there's more pathogenic organisms and inflammation. And that is what then becomes dominant in this area. So Dentistry 2.0 doesn't just treat the biofilm as something that can be permanently removed during a hygiene appointment. No, we know that that biofilm is going to reform. Therefore, the objective is not simply periodic disruption, but the larger objective is ongoing biofilm management and modification. And this is where the ParaProtect system becomes an important part of the model. Customized ParaProtect trays deliver medications into areas that otherwise would be very difficult for the patient to reach, at least consistently. Paragel, which is a very low concentration hydrogen peroxide gel, is part of that home care regimen. And what it does, it helps to disrupt that biofilm environment associated with the pathogenic anaerobic bacteria. And by doing that, we're going to meaningfully change periodontal inflammation, handling those difficult periodontal pockets. We should see a decrease in recurrent bleeding. We should see an improvement in halitosis. And if, like in this situation, these are implants, we should see better implant maintenance or in health. And over time, the periodontal condition should improve. So again, the patients will appreciate that they get the fresher breath and the whiter teeth. But the larger purpose isn't this cosmetic or breath improvement. It's really changing that environment where that disease is occurring, where we detect the biofilm, where we educate the patients so they understand the value of using the ParaProtect, and then we give the patient a practical way to participate in modifying it. When they come back in 3, 4, 6 months, we can see if we still have as much of that red glow. That is the next step in Dentistry 2.0. Early detection of where the risk is, educating the patient, and then helping our patients modify that biofilm. Now, not every area of mineral loss needs to become a restoration. Today, we have what's called Remin gel. And with the Remin gel, we can actually improve the strength of the teeth using these ParaProtect trays. So the IO biotechnology helps to identify and document the areas of biofilm activity and concern. that may not mean as much to patients when we have a white light intraoral image or a radiograph. They may not appreciate the periodontal chart that has 5 and 6 millimeter pockets documented. And again, they may hear us use the terms like biofilm, but they really don't understand what that means. And so what we're going to do is we are going to explain to them that, okay, now we've got this red at the gum line, and we use the hydrogen peroxide perigel to treat those areas. But now that red that's building up in between the teeth, that is where you're more likely to get decay. And what we want to do is we want to strengthen and protect those areas using a Riemann gel also in those PeriProtect trays. So especially if we have early demineralization, this system works very well. So the Riemann gel fits into this part of the Dentistry 2.0 philosophy. Its role is to support an oral environment that favors remineralization and helps strengthen teeth that may be vulnerable to acidic challenges. This allows us to discuss prevention in a way that feels very specific than simply telling the patient, oh, you got to brush better and use fluoride. Now we can show the patients the area of high risk. We can explain that risk. We can provide a targeted home protocol using the PeriProtect trays and the Riemann gel and create an entirely different relationship with the patient. The patient is no longer waiting for us to discover the next cavity. The patient becomes a participant in preserving the tooth structure. So we have early risk detection, and we have a way to modify that risk using our PeriProtect trays, using either the perigel or the Riemann gel. Our patients at this point really appreciate the approach that we're taking to their health. Is that a distinctive way of marketing your practice? I believe so. Is this the way you would want your family to be treated when they went to see a dentist? I think so. So I think this is just a great system and a philosophy. Now, what then happens when we don't detect this early enough and we can't repair this minimally invasively? Well, then we're into the restoring aspect. And the estimates are about 2/3 of class 2 restorations are replacement restorations because of recurrent decay, secondary decay. So what I want to do is I want to use a material that helps protect the teeth. And what we've been using Regen composites, the Regen adhesive and the Regen flow composite liner. There's bioglass in it, and the bioglass helps to neutralize acidity. So in this beaker, what you're seeing is there's acid being added. The pink area is where there's a basic pH, and the yellow is where there's an acidic pH. The pink is staying pink even after the acid is added because there's bioglass fillers on that side. On the right side, the beaker is yellow, indicating that's acidic because that just has your regular fillers that composites have. But by putting bioglass in this composite material, it's able to create a more alkaline environment and neutralize the acidic attack. So what this shows is that, again, we have the Regen bioglass restored material on the left-hand side and just your regular composite on the right-hand side. And what we're able to do is we're able to put a bioactive adhesive into the dental tubules, cure that layer, and then put a very bioglass-rich flowable composite liner on top of that. And at our gingival margins where recurrent decay is more likely to occur. Studies done even back in 2021 show that the use of bioglass containing resin-based composite with or without a bioglass containing adhesive demonstrated inhibition of demineralization at the restorative margin. So the bioglass helps to protect the margins, and that was a study done by Dr. Nate Lawson. So the question that we're asking is, what material can restore the tooth while supporting our larger goal of protecting it? The regen materials with the BioGlass technology fits into this philosophy because they represent a shift away from purely passive restorative thinking to now a restoration that can help protect the tooth once it's placed in the tooth structure. So the objective is to create a restorative environment that supports the tooth restoration interface and helps us interrupt the cycle of recurrent decay, larger restorations, and increasing structural loss. And I think that's another important distinction. All right, material can successfully fill a hole today, but Dentistry 2.0 asks us to think about what happens to that tooth tomorrow, 5 years from now, 10 years from now. Our responsibility is not finished when the material hardens. Our responsibility is to give the restored tooth the best possible chance of long-term survival. So now we go into, when we place that material, that regen bioactive material, how do we cure it? It's because even the best restorative material, if it's not totally polymerized, is not going to protect the tooth as well as it should. Because a better margin creates better longevity. So we have to pay attention to how that material is cured. And the pink wave curing light technology is included in my Dentistry 2.0 model because the curing has to be thorough. It has to be complete. So the goal is to achieve a reliable polymerization throughout the restoration by managing the stresses associated with the curing. So a sophisticated material like the regen bioactive material cannot perform if it's not adequately cured. Dentistry 2.0 examines the entire restorative system, the diagnosis, the isolation, the preparation design, adhesion, material selection, placement, polymerization, occlusion, and the maintenance. And the restoration is only as strong as the weakest part of that system. So what we have to do is we have to use a restorative material that actively helps to protect the tooth. We have to make sure that that material is properly placed and cured. And now we can reinforce that material with a bondable reinforcement ribbon called Rib-On. So there are times when the tooth losses cause significant loss of tooth structure, but let's try to still restore it conservatively. So typically the response to a large restoration has been a move to additional tooth structure removal so we can place a crown. Sometimes that crown is the correct treatment, but Dentistry 2.0 asks us to pause before we automatically escalate our treatment recommendation to a crown. Can the tooth be reinforced instead? Can we conserve more enamel and dentin? Can we provide the patient with a strong and serviceable direct restoration? Can we delay or potentially avoid entering the crown root canal extraction life cycle? Rib-On can give my patients another option. Being a woven polyethylene fiber, it can be incorporated into selected restorations to reinforce the restorative complex and help manage the stresses placed on that restoration and the compromised tooth. It can allow us to provide large but conservative direct restorations that may be more tooth conserving, allow us to structurally reinforce that restoration, probably be a more affordable restoration than an indirect restoration, be actually repairable should something happen to it, and be completed in a single visit. So the story is not that Rib-On replaces every crown, but the story is that it expands our choices. It gives us another rung on the treatment ladder before we remove more natural tooth structure. And once enamel and dent removed, we can't give them back. At least not yet with today's technology. So let's put ourselves in an operatory. Patient comes in, let's say 52 years old, has several existing restorations, bleeding around an implant, and an area of early demineralization near the gingival margin. In Dentistry 1.0, we might clean the teeth, tell it to floss more, wash the early lesion, replace the filling, and reappoint her in 6 months. Nothing about that treatment or its recommendations is necessarily wrong, but now imagine you're using Dentistry 2.0. The experience may be different. We use IOBI imaging to help our patients see where the concerning biofilm is accumulating. For the first time, the red areas make that risk assessment visible to our patient. Now she says, I had no idea that was happening. Now the clinician doesn't have to create fear because the patient has that insight. So we explain that biofilm is not simply found left on the teeth. It's a living community that can shift from a healthier balance towards a disease-promoting state. So we explain that the biofilm is not simply food left on the teeth. It is a living community that can shift from a healthier balance toward a disease-producing state. We introduce PeriProtect and PeriGel to help her manage the difficult areas at home and support the biofilm modification at the gum line. We recommend the use of the Remin gel to help support and strengthen the vulnerable tooth surfaces. And where a restoration is necessary, we use the Regen restorative materials as part of a strategy intended to help to do more than simply fill a preparation. And we place that material carefully. We cure it thoroughly with the pink wave curing light as part of a complete restorative protocol. And then when the tooth has lost a significant amount of tooth structure, we may not yet require a crown. We can consider whether or not using ribbon reinforcement could allow us to conserve more of the natural tooth structure. Then we bring the patient back, we image again, we monitor, we compare. We show her whether her efforts are changing the conditions in her mouth. That is not a collection of products or services. It's a system of care. And that is the differentiated patient experience. That is Dentistry 2.0. So the belief that we need to shatter is that dentistry begins when something breaks. It does not. The disease begins before the hole. The risks begin before there's pain. The biofilm changes before the radiographic lesion becomes obvious. Structural weakening begins before the cusp fracture. And the life cycle of a tooth can begin long before the patient realizes anything is wrong. The second belief we need to shatter is a successful filling means the job is complete. The filling may be complete, but the care of the tooth is not. We still need to ask, has the disease environment changed? Is the patient able to keep the area healthy? Is the remaining tooth protected? Was the restoration cured properly? Is the tooth adequately reinforced? Are we monitoring the patient's risk over time? Dentistry 2.0 replaces episodic repair with continuous preservation. So when people ask what makes our practice different, we do not need to give them a list of equipment or the services we provide. We just say, at our practice, we do more than just look for cavities and repair damaged teeth. We use technology to identify disease risk earlier, help you to see it and understand what is happening, then modify the harmful biofilm or bacteria, strengthen the vulnerable tooth structure, and preserve as much of your natural tooth structure as possible. When treatment is needed, we select materials and techniques intended to help protect and reinforce the tooth, not merely fill the space. So that statement separates our practice from a commodity dentistry. It gives our team a unified story. The hygienist can explain it. The assistants can reinforce it. The doctor can demonstrate it. The treatment coordinator can connect it to value. And the patient can repeat it to their friends and family. So Dentistry 2.0 is about detection. Find the risk and disease earlier. Try to prevent it. Use minimally invasive repair methods with the technology, the iobiocubolus, that helps us reveal the risk and show the patients what we see and make the invisible understandable. The outcome is that the patient is now aware and they take ownership of the problem. We then help to modify that biofilm and shift the biofilm and the oral environment towards health, primarily with PeriProtect and the PeriGel. We help to strengthen the teeth, to support the vulnerable enamel and create conditions favorable to remineralization using our Remin gel, also with the PeriProtect trays. When we have to restore, we repair the damaged teeth with materials selected to support protection and longevity. They're regen restorative materials with the bioglass technology. When we cure that material, we use the pink wave curing light so that we polymerize the restoration throughout the entire depth, especially at the gingival margin, deliberately, and achieve complete curing. Then we reinforce that material when it's a large restoration with Rib-On. Then over time, we re-image, we reassess, and we demonstrate to the patient how their progress is going. So the cycle is detect, reveal, modify, strengthen, restore, reinforce, and continue monitoring. And above all, preserving our patient's oral health. So in the beginning, I asked, does a filling material simply fill a hole? Or should it fill a hole and help protect the tooth? I believe the future of dentistry belongs to the clinician who asks the second question. Patients do not want more dentistry. They want healthier mouths. They want fewer surprises. They want to keep their teeth. They want to understand what's happening. And they want confidence that their dentist is thinking beyond today's procedure. Dentistry 2.0 is how I and my practice have chosen to differentiate our practice. It's not about one machine. It's not about one product. It's not about one treatment. It's a philosophy that connects early detection, patient education, biofilm modification, remineralization, protective restorative materials, complete curing, structural reinforcement, and ongoing monitoring. It is a decision to move from repairing disease to changing its direction. It's a decision to conserve rather than automatically remove. It's a decision to think beyond filling the hole. Because the ultimate measure of our dentistry is not simply how beautiful the restoration looks when the patient leaves. It is how much healthy natural tooth remains and how long can we help the patient keep it. That is Dentistry 2.0. And that's how we stop looking like every other dental practice. So in Dentistry 2.0, we detect the risk earlier, modify the disease environment, strengthen and repair the tooth. If it has to be restored, we restore protectively. We restore conservatively by reinforcing that restoration. We monitor. And just remember, filling does not have to be the starting or the finish line event. Let's try to prevent the start. But if we get to the finish, once I place that restoration, we still have much more to do. We have to prevent recurrent disease. So what I want you to ask, if you're the patient, which practice would you rather be a patient in? A practice that fills the holes, or the practice that understands why the holes occur and builds a plan to help protect your tooth or teeth and the gums that maintain the teeth in the mouth? What I'd like to do is, with this Apex, is build a community. And a community of clinicians trying to do the very best for our patients. I hope you'll come back and we'll go deeper into Dentistry 2.0. Thank you very much. I'll see you again.